Hello everybody, my name is Irene Hibbard and this is my presentation relating to my PICOT question. My initial question was, can a patient's emergency severity index level determine the number of patients per nurse in the emergency department? Unfortunately, this question was too specific, so Professor Srof recommended a broader question still related to the Emergency Severity Index, or ESI, but not to nurse-patient ratios. I changed my question to, how does patient experience relate to a patient's Emergency Severity Index level in the emergency department? So a short description of ESI levels. They are assigned at triage at levels 1 to 5. Acuity level 1 is being the most critical and they require life-saving interventions like CPR, to level 5, which requires no resources and is non-emergent. Level 4s require 1 resource, and then level 3s require 2 or more resources. And resources, for example, are like lab draws, imaging like CTs, sutures done by providers, and multiple more things. And then vital signs can also determine if a patient becomes acuity level 2, if the vital signs are unstable. And then special considerations is based on like a patient's medical history. A little background information about why this question is important is because one of the most watched statistics in the emergency department is left without being seen numbers. So a goal of less than 1% is pretty standard in most emergency departments. So left without being seen means that a patient was triaged in the ER and then left without being seen by a provider. Although most cases an ER does not have less than 1% because of long wait times. Patients leave mainly because they're not satisfied with the care they had or the lack of care they received. This is where my question is important because it comes into play with improving patient satisfaction. This is a watch statistic in the ED because it becomes a patient safety issue as well. When patients leave because of wait times, which has happened in the past, they can become more sick or even lead to death. Even with long wait times, there are ways to improve patient experience and potentially reduce left without being seen numbers. Not only that, patient outcomes are closely related to patient satisfaction, whether they be good or bad. The feedback from patients can also help to see where the ED struggles. A perfect ED would have no patients who left without being seen, and patient satisfaction can reveal the flaws the ED has and the factors involved. The quantitative study I chose was called the Association of Emergency Severity Index Score and Patient and Family Experience in a Pediatric Emergency Department. This study was done to determine if there was a relationship between the patient's ESI score and the response to the key performance indicator question on the patient and family survey. A total of 8,136 patients were involved in the study, and the following prompts were used in the patient family experience survey. How would you rate our facility was the key performance indicator. How likely would you be to recommend our emergency department to your friends or family? And then my child was seen in a timely manner. There were multiple points of data collected, including sex, race, ethnicity, of course the ESI score, prescriptions written, labs ordered, imaging, procedures, time to provider, and length of stay, which are shown in the table in the next slide. Furthermore, the ESI score was not the only variable used to determine a positive or negative key performance indicator response. To be brief, the ESI score had significant association with the patient family experience survey and the univariate analysis, but the multivariate did not. Higher acuity patients had more positive responses compared to lower level acuities. More than likely, this is due to because of longer wait times with lower acuity patients. Higher acuity patients are seen much faster. The clinical significance to this is that we can further understand how ESI score correlates with patient experience, along with all the other variables. Table 2 presents the univariate analysis comparing the patient and family experience survey responses or specific clinical aspects of the encounter with responses to the key performance indicator question on the post-visit survey. Except for prescriptions, imaging, and procedures, all variables were statistically significant in the univariate analysis, with a p-value of less than 0.05. ESI levels were significantly associated with the KPI response, the key performance indicator response, with higher level acuity patients, ESI level 1 and 2, providing more positive responses than lower acuity patients, ESI level 3 and 4. Results from our multivariate analysis are displayed in Table 3 to the right. The point estimate represents the effect of the clinical aspect on the key performance indicator response in a linear regression model. There was no independent association between the ESI score and the patient family survey. A clinical guideline that is related to my question is from the American College of Emergency Physicians. The guideline I found is called Emergency Department Planning and Resource Guidelines. It is an evidence-based outline to identify resources and staff needed to evaluate patients in the emergency department. This policy reviews many resources such as lab tests, imaging, equipment needed, respiratory therapy, qualifications of staff, and many more. The policy guideline is helpful background information to my question. The Emergency Severity Index uses the number of resources a patient needs to help determine their acuity level. It also just gives general information on what an emergency department needs to be functional. Although not directly applicable to my question, it definitely is great background information to understand the emergency department and what it needs to better help patient experience. The qualitative study I chose was not specifically related to my question as well, but does talk about patient experience. The article title is Help Caring for People with Mental Health Problems in the Emergency Department, a qualitative study. The study is aimed at mental health patients and nurses' experience when caring for them. The study included 15 nurses with their years of experience, year of graduation, education age, and all 15 were female. All the nurses were asked 9 open-ended questions regarding the treatment of mental health patients in the emergency department, which will be seen on the next slide. With this information, it is to be understood that this is using the phenomenological research method because it takes the event of mental health patients and has the nurses perceive their experience. The results of the study confirmed how mental health patients are stigmatized, not only in the community, but with healthcare workers as well. In the study, there are actual quotes from the nurse participants that identify how they treat mental health patients differently than a typical medical patient in the emergency department. The nurses displayed fear of mental health patients from their past experiences and discuss how caring for someone with a mental health disorder is taxing. After analyzing the interviews, the information was compiled in an analysis table, grouping the data into 3 main categories that responded to the proposed objectives, which is seen in Table 3. Although this is not related to the Emergency Severity Index, it is very relevant in the emergency department today. The nurses' experience and interviews show how their attitudes change with their interactions with mental health patients. Nurses have biases, whether they know it or not, and mental health patients in the emergency department is one of the major ones seen, and this study just overviews it and proves it. In the emergency department, patients and families experiencing shorter wait times, time to providers, and those in whom a procedure was performed are likely to have a more positive experience during their visit. Although ESI triage score is not an independent predictor of experience, it is associated with variation in wait time and can be used as a proxy for these measures to design interventions aimed at improving the experience of patients and their families. Suggestions to improve patient experience include the obvious improving wait times and rounding on patients and giving them updates. It is also important to review what resources the emergency department is lacking and what procedures and policy needs to be in place to improve those wait times as well. The most important thing I learned from this whole class is how important evidence-based practice is. Not only is it important, but there are so many factors that go into making a study based on evidence-based practice. Along with that, finding the research also was more complex than I had imagined. After this class, I'm more able to search for evidence from all the databases that were suggested, Cochrane, PubMed, and CINAHL. I can also determine when a source is of good quality or not as well. Differentiating qualitative and quantitative evidence and understanding how they both have strengths and weaknesses when using them to support a question was also something I found useful. I also never knew about the different models that were used in our books, and I also learned how we can use those to implement evidence-based practice in healthcare settings. And this is the list of references I used. And thank you guys for watching.